This conference will now be recorded.
MRI is done to rule out CP angle tumors and other intracranial causes such as multiple sclerosis or any demyelination, typically seen in multiple sclerosis and small vessel ischemic changes. So, treatment, multimodal treatment, because most cases are idiopathic. So you have to do a battery of investigations to find out the specific cause, and treatment should be started early also for better results. So bed rest oxygen therapy is carbogen inhalation of 5% oxygen and 95%, sorry, 5% carbon dioxide and 95% oxygen. Oral steroid treatment, prednisolone. There are three actually. The body produces hydrocortisone from the adrenals, and the steroid doses should be adjusted in such a way that to meet the highest demand. Like in case of stress, the steroid secretion goes up. So as you know, the adrenal is what is it? Fight, flight, and fright. So in these three conditions, there is overproduction. There is almost 200 to 300 milligram of hydrocortisone is secreted. So we, instead of hydrocortisone, we give prednisolone. So prednisolone is given in the dose of 1 milligram per kg body weight, maximum 60 milligram per day in 2 or 3 divided doses. Proton pump inhibitors are given alongside with steroids, because they cause gastritis, and these are oral steroids. So oral steroids, if used for a prolonged period of time, lead to various side effects like Cushing syndrome and worsening of diabetes, and so many other problems. Peptic ulcer can get aggravated, acute angle glaucoma. It can also cause the steroid-induced cataract. So many side effects are also there with prolonged oral steroid treatment. So you have to balance the positive with the negative. Nowadays, and second thing which is gained popularity is intratympanic injection of steroid. So as an alternative to oral steroid, it has shown to penetrate the inner ear effectively. So this intratympanic steroid injection uh, can be given either by keeping a small, what you say, a grommet through which you can just push the steroid, or you can also use a lumbar puncture needle, a very fine needle, gauze needle, to instill the steroid. So usually they use solumetrol, which is methyl prednisolone, and the prednisolone is 4 times more potent than hydrocortisone, and methyl prednisolone is 5 times more potent than hydrocortisone, and dexamethasone is 25 times more potent than hydrocortisone. So methyl prednisolone can be given, and these are absorbed slowly through the round window as well as through the oval window, mostly through the round window. And but the main problem with intratympanic injection of steroid is uh, that the absorption is not constant. Like suppose you say a person is having had some ear pathology like ASOM or CSOM, and the drum has repaired or there is a perforation. So there will be some amount of fibrosis of the round window or thickening of the round window. So that will hamper the absorption of the solumetrol or methylprednisolone, and vasodilators like xanthanol, nicotinate, glycerol, beta-histine are also being given, and glyceryl trinitrate nitroglycerin patch also helps to relieve vasospasm and improves blood supply to the nerve tissue. So antiviral course, valsivir, acyclovir, famciclovir are also being tried. Now, Salvage treatment, what do you mean by salvage treatment? Salvage treatment means the cases which are refractory to oral steroids needs salvage treatment. So in salvage treatment, in the sense, two things are available with us. One is the intratympanic steroid, another is hyperbaric oxygen therapy. So hyperbaric oxygen therapy means delivering 100% oxygen to a patient at pressure greater than 1 atmosphere. So it is seen that if hyperbaric oxygen therapy is used within 3 months of the hearing loss, then the results are good. And particularly when it is used in case of severe to profound hearing loss. So this is a very good thing, but you should use this hyperbaric oxygen therapy within 3 months of onset of the sudden sensorineural hearing loss. After that, the results are not that much predictable. And number two is the what you say, the complications. So hyperbaric oxygen therapy can lead to uh, injury to the ear, to the eustachian tube, to the paranasal sinuses, and also to the lungs because of the pressure, because of the pressure. And also it can cause oxygen poisoning, can also cause oxygen poisoning. So we have to be careful about it. And also, patients who are claustrophobic, they usually don't comply well with hyperbaric oxygen therapy. So these are very available in highly selective centers, and it is very costly and also a pretty lengthy treatment. So you have to spare every day 1 to 2 hours every day for a week, and minimum 5 to 10 sittings are required. So some people may not afford that much time every day. And number two is the cost is very costly. And third is availability in all the centers. So others are stellate ganglion block, and it blocks the sympathetic activity and results in vasodilatation of vertebral artery. So if this can be effective if used within 2 weeks of onset of sudden sensorineural hearing loss. Surgery, exploration of middle ear with repair of inner ear fistula is recommended in patients with clear history of sudden hearing loss associated with diving, straining, altitude change, or recent autologic surgeries. So you know that even stepidotomy is like a controlled fistula. Penetration surgery, which was done previously, is a controlled fistula. So you can, if suppose you have done a stepidotomy, and then what happens? It results in a perilimb fistula. So that also can present to you with sudden sensorineural hearing loss, vertigo, and tinnitus. So these are the conditions where you can uh, do some surgical treatment. And another one is the acoustic neuroma, which I will be talking in the subsequent unit. So where only in 5 to 10% of cases you develop sudden sensorineural hearing loss. So that also can be treated with surgery. So treatment of specific cause, anticoagulants like heparin in case of thromboembolism if you suspect, low molecular weight dextran to treat hypercoagulable state, thyroxine supplementation for hypothyroidism, treatment and control of diabetes mellitus, hypertension and hyperlipidemia, and treatment of bacterial labyrinthitis. So these are all can be medically treated, so you can start the treatment as early as possible. But the most important thing is, as a clinician, you have to keep this condition in mind, and so that you can clinically look for the signs and symptoms, and then subsequently plan out your investigation and then deliver the treatment. Rehabilitation of hearing impairment can be done using hearing aids when residual loss is not profound, or cochlear implant when recovery is minimal and profound hearing impairment is present. So, but cochlear implant is quite costly, almost cost around 12 lakhs, so which very few people can afford. So, try to intervene it as early as possible so that you did not implant every other person. Recovery, complete recovery to almost within 10 decibel of pre-hearing loss is known as complete recovery. Partial recovery is recovery to within 50% or of more of hearing pre-hearing loss. No recovery is less than 50% recovery of pre-hearing loss. So if you have the record, if you have the record with you and the patient has done a previous audiometry, and then you can compare and say whether the recovery, or what you can do the day the patient comes to you, you do a audiometry, start the treatment, and then after the treatment gets over, you do another follow-up audiometry, and then you can compare the results of whether your treatment was successful or not. And lot of permutation combination have been tried actually, that is hyperbaric oxygen therapy with oral steroid, or hyperbaric oxygen therapy with intratympanic steroid, but all those studies have shown that combination of treatment doesn't give you added advantage to the patient. So usually the first line is oral steroid, and then the salvage therapy is you go back to intratympanic steroid, or you can go for hyperbaric oxygen therapy. Other supportive treatment, all you know, um, depending on what clinical condition the patient has present in. So spontaneous recovery rate for patient with sudden sensorineural hearing loss ranges from 47 to 63%. Patient in whom there is no change within 2 weeks are unlikely to show much recovery. So you should not promise the patient ki with this treatment you will get back your hearing. So this type of false promises you should refrain yourself. Rather, you start the treatment as early as possible, and you tell the patient, let us wait and watch how you progress. So four variables have been shown to affect the recovery. So times in onset. So if it is say the earlier the better, and if it is a delayed one, and suppose a patient comes after 4 months, 5 months, we have seen in OPD patient coming almost after a year or so. So in those cases, the chances are quite poor. In fact, there is almost no chance at all. The audiogram type, uh, here the initial phase, I told you, you have a ascending type of graph where there is lower frequency loss. Then you have the middle frequency is involved. It is a tented graph you get. Then you get the sloping graph. That is the higher frequency. So patient coming to you with a sloping type of audiogram, they don't do well. They don't do well with the treatment. Vertigo, patient presenting to you with vertigo along with hearing loss carry a poor prognosis. So that you should keep in mind. Patient. So you should always ask for whether vertigo is there or not. So if vertigo is there, then you have to tell the patient about what to expect from the treatment. Age, with increasing age, obviously the chances of recovery or chances of getting back the hearing totally comes down with age actually. So this finishes your sudden sensorineural hearing loss. Any doubt? Hello? Any doubt? Can you hear me? Hello.
No doubt, sir.
Ada, you can hear?
Yes, sir, we can hear you, sir.
Acha, now can you see this PowerPoint presentation of acoustic neuroma?
Yes, sir.
Okay. So, Acha, at the end of the class, just let me know what are the courses which are still remaining to be covered in all the chapters, nose, ear, larynx, and all. And tomorrow, Dr. Satik will be taking the class. You can let him know, so that in the next week onwards we can prepare our schedule according to the topics you have given. What are the remaining topics? Okay. Okay.
Yes, sir.
Hello. Fine. So coming to acoustic neuroma. So acoustic, the word indicates eighth nerve, and neuroma indicates a benign tumor of the eighth nerve. So the most common benign tumor arising in the posterior cranial fossa arises from abnormally proliferative Schwann cells, which envelop the lateral portion of vestibular nerve in the internal acoustic meatus. So the internal acoustic meatus is the area from where the tumor starts. So it develops from the Schwann cell. So it is also otherwise known as schwannoma. And these Schwann cells, the function of Schwann cell is to produce myelin sheath. So for myelinated nerve, they produce the myelin sheath. So synonyms are acoustic neuroma, neurinoma, neurilemoma, or even you can say schwannoma, and cerebellopontine angle tumor. So cerebellopontine angle tumor is not one, but a group of tumors. Among them, acoustic neuroma is one. Others are meningioma, arachnoid cyst, then congenital cholesteatoma can also occur. Metastatic deposits can also occur in the cerebellopontine angle. Okay, so among this one, the most common is the acoustic neuroma or the schwannoma. Here you can see the picture. This is a MRI gadolinium enhanced. You can see this is the tumor, and this is the part which goes into the internal auditory meatus. You can see this is the meatal part, and this is the intracranial part. And here you can see the intracranial part pressing onto the brainstem area and a small intrameatal part. So basically, if you see, the tumor has two parts. One is the intrameatal part and the intracranial part. So what happens is the tumor starts somewhere here. Okay, so that region is known as Obersteiner. I'll tell you that name. I don't have it here. This is Obersteiner Redlich junction zone. So this is the area from where the tumor starts. Obersteiner Redlich junction zone. So the tumor starts here in the internal auditory meatus, and because the space is quite trapped up here, so it prefers to grow intracranially. And then this part is the extrameatal part. This is the intrameatal part, and this is the extrameatal part. So the extrameatal part then grows into the cranial cavity, into the cranium, and then slowly causes different symptoms. In fact, it is a very slow growing tumor and grows at a rate of 1 to 3 millimeter per year. 1 to 3 millimeter per year. So this is MRI. Gadolinium is the dye given, and you can see very nicely the tumor is demarcated. So coming to the cerebellopontine angle, the boundaries are anteriorly you have the trochlear, the abducen nerve, sorry, and the lateral aspect of the clivus, and laterally you have the medial surface of the petrous part of the temporal bone, and then medially you have the middle cerebellar peduncle, pons, and the ventral surface of the cerebellum. Superiorly, you have the fifth nerve, and inferiorly, you have the lower cranial, 9, 10, and 11. And posteriorly, you have the flocculus alone of the cerebellum. So, contained within this space are cranial nerve 7 and 8. So, and also the premeatal, meatal, and postmeatal segment of anterior inferior cerebellar artery, and the porus of the internal auditory canal or internal acoustic canal. So this is the overview. You can see this is the sixth nerve over here, which is the anterior boundary. This is the fifth nerve, which forms the roof. Then here you can see this is the clivus over here, and the clivus forms the anterior boundary along with the sixth nerve. Laterally, you have the petrous part of the temporal bone here going right up to the petrous apex, and then here you have the cerebellar peduncle, the pons, and midbrain, and then here you have the flocculus of the cerebellum posterior. Inferiorly, you have coming from here, you have the lower cranial nerves, 9th, 10th, and 11th. Little bit about the internal auditory canal. So it develops a lateral and posterior path in the relation to medial surface of temporal bone. So the internal auditory canal is a gap, and it lies perpendicular to the petrous part of the temporal bone, and roughly the length is 1.2 to 1.4 centimeter from porus to fundus. So porus is the medial opening and fundus is the lateral opening. So where it enters the inner ear. The lateral portion of internal canal is divided into superior and inferior compartment by the falciform or transverse crest. So if you see, this is the canal, and there will be a crest, and this crest is called as the crista falciformis or transverse crest. And and then the upper part of the uh, fundus of the internal auditory canal is again vertically split by a Bill's bar, that the vertical crest, into two compartments, and the lower part is not divided actually. So if you see from the lateral aspect, that is from the inner ear side, you will find that the fundus, and superiorly in between you have the crista falciformis dividing into upper and lower compartment. Upper compartment is again divided into two by the Bill's bar. One is the anterosuperior and the posterior-superior. The anterosuperior part is the pathway for the facial nerve, and the posterior superior is the superior vestibular nerve, and the antero inferior is for the cochlear nerve, and the posterior inferior is for the inferior vestibular nerve. And the inferior vestibular nerve, just at the periphery of the internal auditory meatus, you have a small opening that is called as the through which the singular nerve passes, and this singular nerve goes and supplies the ampulla of posterior semicircular canal. So, and the inferior vestibular nerve primarily supplies the saccule, and the superior vestibular nerve mainly the utricle and the lateral canal. Okay, and the superior vestibular nerve supplies the superior ampulla of the superior semicircular canal. Okay, and the cochlear nerve is not a single opening, but multiple openings are there, and through which the cochlear nerve is formed. So this all I have discussed. So here, this all we have talked about. So the singular nerve, the inferior vestibular nerve fibers from the macula, and the cochlear nerve leaves the internal auditory canal through a multi-perforate osseous plate to enter the cochlear modulus. Okay. here you can see this is the petrous part of temporal bone that has been drilled open, and you can see this C is the facial nerve, and this is the nervus intermedius, which is the sensory part of the facial nerve. It accompanies the facial nerve with a different nerve, and inside the internal auditory meatus, it fuses with the facial nerve. And you can see B. This is the, you can see here the anterosuperior, the posterior superior. This is the B1 is the superior vestibular nerve, and E is the here you can see very nicely the E. E is the inferior vestibular nerve. A you can see multiple here, the cochlear nerve here and here. So it is occupying the antero-inferior. E goes posterior-inferior, and here is crista falciformis. You can see very nice the crista falciformis. Okay, and here somewhere you will find the Bill's bar. Here you are. So these are the different position of the nerves. This is inside the internal auditory meatus, and this, when dissected, it will medially from the pontomedullary junction. You can see this is the B. C is the facial nerve here is going, and B is the superior vestibular nerve, and A you can see is the uh, cochlear nerve here, and F here is the singular nerve. No. And this 3 is the glossopharyngeal, and 4 you can see very nicely is the vagus, and 5 here is the dural septum. Okay, and this here is the antero-inferior cerebellar artery, which is a branch of the basilar artery. Okay, so these are the different what you say the anatomical thing you are getting in the cerebello-pontine angle. And D here, this is the internal auditory artery. The internal auditory artery also is one of the contents of the internal auditory canal. So along with the nerve, we have the internal auditory artery. Etiology is unknown, but recent advances in molecular biology indicate that there is a defect in the chromosome 22q, which may be responsible for development of both unilateral sporadic and bilateral vestibular sonoma in neurofibromatosis. So that is von Reckling-Hossen's disease, where you get bilateral vestibular sonoma, and their presentation is very early compared to the unilateral sporadic cases. So these patients, the von Reckling-Hossen's may present in the second, third decade of life, whereas unilateral cases usually fifth or sixth decade of life they present. And most common tumor involving the cerebellopontine angle, more than 90% occur as unilateral and non-hereditary reasons. So remaining neuromas are manifestation of neurofibromatosis, that is von Reckling-Hossen's disease. So acoustic neuroma in neurofibromatosis 2 are characterized by onset early in life, often before the age of 21 years. Just now I told you, and most of which are diagnosed between the age of 40 to 60 years. So, because this is a very slow growing tumor, no, so the presentation is usually pretty late. And the presentation also will tell you the size of the, will give you a clue, the size of the tumor. Now, the earliest presentation and in the most constant presentation is in case of non-hereditary, let us speak about acoustic neuroma, is unilateral hearing loss. The patient will have unilateral hearing loss plus or minus tinnitus. So tinnitus may be there, may not be there, and progressing over a period of time. That is the most common presentation. Then next is the other is called as the Listelberger sign. That is the loss of sensation of touch in the posterior bony meatal wall or posterior wall of the external auditory canal. So that is known as the Histelberger sign. Loss of corneal reflex is another indicator. These two are indicates that the tumor is already touching the trigeminal nerve. So if you come to, if you see here, let us go back to the picture. Here, if you see a tumor present in the internal auditory meatus, we have only hearing loss. And even though facial nerve is one of the contents of the internal auditory meatus nerve, somehow or the other it escapes being paralyzed. You don't get patient presenting to you with facial nerve palsy in case of acoustic neuroma. And in certain cases, you find that the internal auditory meatus will be widened, and some amount of bone erosion will be there. So that is why when you are taking an MRI, you have to compare the internal auditory meatus of both the side to see for how much of bone erosion has happened. Bone erosion in case of acoustic neuroma is primarily due to pressure effect and secondarily due to new angiogenesis or new vessel formation or due to increased blood supply or to the because of the tumor. So the bone, but the bone resorption or bony destruction is mostly due to pressure effect of the acoustic. So as you know, as I told you, it's a very slow growing tumor. So the intrameatal part from here slowly develops into, comes into the intracranial part, because here it is, the space is not there, and the tumor, you know, grows where the resistance is less and a more space is there. Then they come into the pontine cistern here. The pontine cistern here is a comparatively spacious and devoid of any vital structures. And then you will get a silent phase where there won't be anything. And then slowly, the tumor gets slowly little more bigger, and when it gets bigger, then it touches the trigeminal nerve and it comes and touches the midbrain. So, and then when the trigeminal nerve is touched, then you get the symptom of Histelberger sign, loss of corneal reflex. And by this time, what happens? There will be a definite stretching of the vestibular nerve, the facial nerve also will be stretched. And then there will be next phase where the tumor goes sufficiently large enough to compress the brainstem and then the fourth ventricle. So once there occurs compression of brainstem and fourth ventricle, then patient will develop hydrocephalus, because the uh, what you say, the CSF outflow is now hampered. So that will lead to development of hydrocephalus. So you have a stage where you have only otological symptoms, and then a phase where you have, although the tumor has gone intracranially, but there is no presentation. Then you have a phase where the tumor goes and touches the trigeminal nerve, and then you have the Histelberger sign, you have the loss of corneal sensation, and with more involvement of trigeminal nerve, you have hyperesthesia and paresthesia of the face on the ipsilateral side, and then you have a stage where the tumor presses on the brainstem, on the cerebellum, and then the cerebellar features start to develop, ataxia, dysdiadochokinesia, all these things, broad-based gait, and then the next phase goes where there occurs compression of the fourth ventricle, causing severe impairment of CSF drainage and leading to raised in intracranial pressure and coma. Patient will go into coma also, and development of hydrocephalus. So this is a very slow progressing tumor, and these are the different phases. And the clinical complaint will give you a rough estimate in which stage you are seeing the patient right now. So they are benign, well circumscribed but unencapsulated tumor that arise from Schwann cells of vestibular nerve. Hence the term vestibular schwannoma or vestibular neurolemoma is used. So previously it was thought to be arising mostly from superior vestibular nerve, but now they are saying mostly it arises from the inferior vestibular nerve. So these either superior or inferior vestibular nerve is the place from where the tumor arises. But it can also arise from the facial nerve. It can also arise from the cochlear nerve. So it is not that it is hard and fast that it will arise from the vestibular nerve, because that's the acoustic. Acoustic means you both. So historically, the superior vestibular nerve sheath was thought to be the site of origin, giving rise to nearly two-thirds of tumor. But recent studies have shown inferior vestibular nerve to be the predominant site of origin for these tumors. So you keep it in mind. So it's not only superior, it is inferior. Even cochlea also can. So see, rarely cochlear portion of eighth nerve or the facial nerve is the site of sonoma. So, but they're rare, but can occur. So it has been thought that vestibular schwannoma arises at the Obersteiner-Redlich junction zone of the vestibular nerve, the region at which the Schwann cell and the neuroglial supporting cells meet. So the neuroglial supporting cell comes along with the nerve from medial to lateral, the Schwann cells, and then what happens is there occurs as the Schwann cell grows, these neuroglial supporting cells they oppose, and then the Schwann cells starts heaping up. So the advantage of this is the tumor never perforates into the nerve. Rather, it is there is a definite plane between the nerve and the tumor. So that is the advantage, because it arises from nerve sheath. It doesn't what you say it just pushes the nerve, but doesn't infiltrate the nerve. So you always have a plane to dissect out the tumor. So this is a classification of the size of the what you say the acoustic neuroma, and this is based on the largest extrameatal diameter, and it is further recommended that a note should be made if the fundus is empty or filled by tumor, or whether the tumor is solid or cystic in nature. So the tumor can be of two types. It may be a solid, it may be a cystic in nature. I'll come to that. So based on this classification, you have grade 0 is intrameatal. And they have mentioned it intrameatal as 0. Then grade 1 small tumor is 1 to 10 millimeter. Grade 2 is a moderate, 11 to 20. Grade 3 is moderately large, 21 to 30. Grade 4 is large, 31 to 40. Grade 5 is a giant tumor, more than 40 millimeter or 4 centimeter in diameter. So, and then coming to the two types I told you, solid and cystic. The solid tumor has a more predictable course. For example, predictable course in the sense that you can, in certain patient, wait and watch, or wait and scan. That is the principle of wait and scan. Regularly, you follow up the patient. But in case of a cystic tumor, you cannot do that, because sometimes there will be a rapid increase in the size of the tumor. So that is how the cystic tumor they present with sudden hearing loss, and there might be a rapid increase of the size of tumor, just like you say a thyroid tumor. Suddenly there is an increase due to cystic degeneration. So suddenly the patient will present to you acutely, saying that since last few days my thyroid has become very big. So that if you do ultrasound, you will know it that there is definite cystic degeneration. So cystic tumor is a separate entity and should be dealt then dealt little separately from the solid tumor, in the sense that there is no wait and scan for cystic tumor. In those cases, you have to operate. So cystic tumor should be operated as early as possible. Now, Diagnostic evaluation, history, unilateral tinnitus, followed by slowly progressive. No, it's the other way around. Sorry, the progressive hearing loss is more important than tinnitus. Or in 5 to 10% cases, you have a sudden sensory neural hearing loss. So oral fullness may be sensed due to hearing loss or tumor bulk, decreased facial, corneal, and oral sensation, headache, tremor, ataxia, gait disturbance, visual loss, dysphagia, aspiration. These are all this dysphagia, aspiration, hoarseness, shoulder and tongue weakness are all involvement of the lobe cranial nerves. And this will occur only when the tumor becomes giant, that is more than 4 centimeter in diameter. And in case of early presentation, you try to find out the family history of von Reckling-Nossen's disease. And neuro-otologic examination should be done, includes evaluation of audiovestibular, and cerebellar, and cranial nerve function. Now, auditory function. So, auditory function, mostly what we do is we do a pure tone audiometry, and also we do is a speech discrimination score. So based on that, they have categorized into 4 groups. Group A, where the pure tone audiometry loss is less than 30 decibel and the speech discrimination score is more than 70%. Then group B, where the auditory PTA level is 50 less than 50 decibel and the speech discrimination score is more than 50%. Group C, where the PTA loss is more than 50 decibel and the speech discrimination score is more than 50%. And group D is where the speech discrimination score is less than 50%. So this is by the American Academy of Otolaryngology and Head and Neck Surgery. They have graded this hearing, what you say, uh, the hearing pattern in a acoustic neuroma case. So based on that, you can classify your tumor belonging to which group according to the hearing loss. And there is another one is that uh, what is called that is called word discrimination score. That is another system. So word discrimination score, in which they have one is a phase 0, where the word discrimination score is 100%. Then phase 1 is 99 to 70% word discrimination score, and then phase 2 is 69 to 40%. Phase 3 is 1 to 39%, and phase 5 is 0%. So also based on that word discrimination score also, you can also tell where the acoustic neuroma stands. So you have one on the size, one on the audiometry and speech discrimination score. Another you have is the word discrimination. So these 3 things are there to tell what is the what type of or which stage of acoustic neuroma tumor you are dealing with. Other things you can do is you can do a BERA, that is auditory brain stem response audiometry, which has a 90% sensitivity for the diagnosis. So here you have to look out for the wave 5, increase in the latency of wave 5 or delayed peak, that is what it is called of wave 5, is a diagnostic of acoustic neuroma. And intraoral latency is what we look for, particularly in case of acoustic neuroma. Vestibular study, you can do electronystagmography, even vestibular evoked myogenic potential also you can do. But mostly these are all superseded by the MRI and hearing. So mostly you are concerned with two things. What is hearing? What is the hearing and what is the size? So these two will dictate the approach. What approach you take as a surgeon. So this is what we are talking about. Imaging study provide a definitive diagnosis, contrast enhanced T1 weighted MRI, the gold standard. But high resolution T2 images are also excellent in detecting internal auditory canal lesion, internal acoustic canal lesion. So this painful technique carrying significant morbidity, such as posterior fossa myelography, gaseous or opaque contrast CT, are rarely necessary today. So, but they have their indication. Because suppose one patient has having claustrophobia, he or she cannot stand the MRI because that this MRI scanning will take almost 30 to 40 minutes. Or a patient is having a implant in the body, a metal implant, say a bypass or a cardiac implant. So in those are contraindications for MRI scan. So in those cases you can go for this posterior fossa myelography or opaque contrast CT. So this is the tumor you can see here, and this is the T1 weighted magnetic. This is the plain MRI, and this is after gadolinium. You can see very nicely the contrast is taken, and even the multiple cysts you can see inside the tumor. So this is like a cystic degeneration or a cystic type of presentation of acoustic neuroma. So this cystic type has a little comparatively compared to the solid type the cystic type is more aggressive and grows at a very rapid pace, and thereby the presentations occur also very fast. So management basically divided into three groups, you can say three or four. One is the most definitive is the surgery. Then you have the stereotactic radiation therapy. Then you have that is called as the radio surgery, and then using that is by use of a gamma knife or a mostly a gamma knife, and wait and watch or wait and scan principle. So the radiation therapy goals are long-term prevention of tumor growth and maintenance of neurologic function and prevention of new neurologic deficit. So patient who demonstrate tumor recurrence after surgical removal may undergo salvage radiation therapy. Or those suppose the patient is not fit for, because this surgery, lateral skull base surgery, it takes a long time and it highly morbid surgery. Not every patient can tolerate it. So those who are not fit for surgery or general anesthesia can be offered the stereotactic radiation therapy. So here what they do, there are two patterns of giving. Either you give a fractionated dose of radiation or you give a single bolus dose. So here what the advantage, this stereotactic radiation therapy means where radiation are given from all around the tumor, and the dose is made in such a way that the maximum concentration occurs on the tumor itself. So there are two ways of giving. Either you give a single dose, single shot, or you give multiple shots. Now, when you give a single shot, no, the results they compared and they found that those who take multiple low dose treatment, they do well with hearing loss because they retain their hearing. Why? Because when you are giving a stereotactic radiation to the tumor, no, the tumor is damaged. Also, the nerves are also exposed. They are nearby only. So they also sustain some damage. But as you are giving at an interval of time, so the nerve will recover to some extent, but not the tumor. Tumor cannot recover, but the nerve has the power to recover to some extent. Thereby, you can prevent neural damage also. And other than that, the development of burn radiation burn to the skin, or development of brain edema, all those things doesn't occur with multiple fractionated dose. So surgical management, so microsurgical excision has been the treatment of choice for vestibular schwannomas. The 4 microsurgical approaches to vestibular are like you can go for a translabyrinthine approach, or a middle fossa approach, or a retrosigmoid. Now, before starting or deciding on which uh, um, path to take, 2 or 3 things determine uh, which route to take. One is the hearing. The most important thing is the hearing. So, if the patient has serviceable hearing, then obviously you can choose the middle fossa approach or the retrosigmoid. And if there is no serviceable hearing, then you can go with the translabyrinthine. If the tumor has a large intrameatal part, then you go ahead with the translabyrinthine and middle fossa. And middle fossa approach good access to fundus. Someone has kept your please mute your mic. Hello. Someone has kept the mic open. Please mute your mic. Hello. Can you hear me? Hello. So the translabyrinthine approach, the advantage of translabyrinthine approach is there is no cerebellar retraction. You did not retract the cerebellum. Where in retrosigmoid approach you have to retract the cerebellum. Any size of tumor can be removed. An early identification of facial nerve is very, very important. You have to identify the facial nerve, and ease of access of facial nerve graft also. But the disadvantage is it destroys residual hearing. Whatever hearing is there, totally it goes off. But still, now there are surgeons who are doing a conservative translabyrinthine approach where they isolate the cochlea and only take out the vestibule, and they isolate the cochlea, thereby preserving some amount of hearing. That also they are doing. And then CSF leak. CSF leak is a major headache in a translabyrinthine. Middle fossa approach, possibility of hearing preservation and good access to the fundus, but trapped up access to cerebellopontine angle. Here, temporal lobe retraction can lead to temporal lobe aphasia. A limit to size of tumor that can be removed, and risk to the facial nerve is there. And in retrosigmoid, there is cerebral retraction. Very poor view of the fundus, facial nerve graft is difficult, and post-operative headache will be there. So, with this, in the next class, I will just briefly tell you the advantages of each, and we will wind up the acoustic neuroma. Any doubt? Year date? Any doubt? Hello?
No, sir.
Okay. Okay. Thank you.
Thank you, sir.